Okay. Please let me know if you see my screen. Okay. I think I can see it.
Yes.
Okay. Okay. This is good.
Yeah,
Okay.
that's good. That's good.
Okay. Thank you for joining today's webinar. And we are very glad to be joined by other NRHA staff members. On behalf of NRHA, I want to echo a big thank you. We know you are all very, very busy, but you took the time off to join us this afternoon for the webinar that is in partnership with Transform America's Health and Advancing States. So thank you so much. So I just want to give a brief overview about our agenda for today. So I will give a brief overview about who NRHA is and what the National Rural Age Friendly Initiative is about. We'll also give a brief overview of what elder mistreatment and abuse is, and that will be followed with a presentation by Megan Wolf, who is with Trust for America's Health on their newly developed Elder Mistreatment Prevention Toolkit for Public Health. That will also be followed by discussion questions. We'll make sure to have discussion sessions so that if you have any concerns, any suggestions, you let us know. Then we'll end with next steps and closing remarks. So that is the agenda for today. I will just move forward to talk about who NRHA is and what the National Rural Age Friendly is. We don't have a short name for it, so I will still be saying National Rural Age Friendly, or if I say initiative, it's still the same as the National Rural Age Friendly Initiative. So NRHA is basically, I know most of you are familiar with NRHA, but for the benefit of those who don't know about NRHA, I just want to say this, that it's a non-profit, non-partisan organization, and their aim is to improve the rural health in America. Currently, we have over 21,000 members that we share our resources with. So we are very pleased and we are very happy to have all of you as our members. Thank you so much for always being very collaborative with us and always joining our meetings and sharing your insights. So our mission is to provide leadership on rural health issues, and we do this through advocacy, communication, education, and research. So this is the initiative. I don't want to give the full name. It is sponsored by the Johnny Hartford Foundation, and the basic mission is to improve the health of rural older adults. We also achieve this through four approaches, which is convening, communication, educational activities, and community health workers training. With the convening, we convene interest group members. We also have meetings like this webinar, which is all under the convening. With the communication, we have several articles, we have blogs, we also develop policy papers, and all these are being recommended and suggested by the interest group members that during our convenings, interest group meetings. And we also develop like educational activities. We go for webinars to give presentation on the progress of the initiative. We join our partners initiative. We also present during NRHA initiatives. And the main focus of the initiative is community health workers training, which is to help improve the age-friendly health system. So currently, we've trained several community health workers in Texas, and we are very pleased with our numbers. Not just our numbers, community health workers are also testifying that it's really good to be trained on the four frameworks of a friendly system. So we are very proud of the initiative and the work so far, how far we've gotten to. So these are proud partners. We have seven main partners with the initiative, but aside these partners that are listed here, I will not mention all their names. We have several other partners that we actually collaborate with. You can see Tifa is not here, but today we are collaborating with Tifa on the elder abuse mistreatment webinar. We have more than 10 other partners that we collaborate with to ensure that rural older adults age well in rural areas. So I am very proud today to have Kathy Greenlee, who is a senior director of Elder at Advancing State, and Megan Wolf with Tifa to present today on the elder mistreatment and abuse prevention webinar. So with that, I would leave it to Kathy Greenlee, who is the facilitator for today's webinar, to take off
Thank,
from here.
thank you so much, Becky. Since I don't usually hang out with public health folks, let me make sure you know who about Advancing States. Advancing States is the national association that represents the various state units on aging, state departments on aging, and we also represent Medicaid agencies in the state, the ones that are running the Medicaid waiver program. So we're very, very focused on state work. I served as the U.S. Assistant Secretary for Aging from 2009 to 2016. I was the Secretary of Aging in Kansas for 3 years prior to that. I think before we start, it's always important to me, at least, to be grounded in the why. Megan has a ton of good information for you in this toolkit, but I always want to start and talk about the people that we're trying to help. We're going to talk about abuse, and in that respect, we're talking about physical abuse, sexual abuse, financial neglect, and self-neglect. With regard to self-neglect, it's important that you know that across the nation, this represents 50% of all cases reported to Adult Protective Services. That can be higher in some states. And within the APS body of work, they're seeing increasing numbers of reports of financial exploitation, and those cases are getting even more complex. AARP issued a report in 2023 that documented that the annual losses to financial exploitation for older adults in this country is $28 billion. So financial exploitation and self-neglect are huge. With regard to abuse itself, as we look at prevalence, the most commonly cited number is the National Elder Mistreatment Study that was done in 2008 that says 1 in 10 older adults are abused. But what we know from that study is it's too low because it was a study done on community dwelling adults, so no one in a congregate setting, and people who could consent to be interviewed. The IRB requires that you get consent. And so we know that those numbers are likely higher. There are some small sample studies that show that the prevalence of elder abuse is higher for people with Alzheimer's disease or other cognitive impairment, so it can be higher. It seems almost trite to say that elder abuse is a physical challenge for people. There's a good report Dr. Mark Lax did that shows that people who are victims of elder abuse have a 300% increase in morbidity and mortality. They're more likely to die. The two greatest risk factors, and there are many, but the two greatest are social isolation and cognitive impairment. I have had the pleasure of facilitating this initiative, the National Rural Age Friendly Initiative, for the last several years. And I want to just reiterate here what I always say there, which is rural aging is not a subset of aging. You don't take any issues off the table when you talk about rural, whether it's rural elder abuse, rural aging. It is a setting. The issues facing people in urban areas and rural areas, whether it's general aging or elder abuse, are the same. The differences are the resources it takes to support the need, but the issues are not different themselves. There's some research that's done, and not a lot, on rural elder abuse. So I just want to give a shout out to Dr. Carrie Henning-Smith with the University of Minnesota Rural Health Research Center. She's been looking at protective factors, and I think it's something important to know for the context of this discussion that the social cohesion that older adults have in rural communities is a form of protective factor for them. I grew up in a small town. It doesn't necessarily seem rural because it was close to a bigger city, but I grew up in a small town and we knew the older people in our community. They're the former people who used to teach us or provide support in the community. So that social cohesion is really important. This is an interesting intersection, this work of three initiatives that have been funded by the John A. Hartford Foundation. So I just want to give them props and a shout out. The National Rural Age Friendly Initiative, the Age Friendly Public Health Systems, and the National Collaboratory to Address Elder Mistreatment, where we've been focusing primarily on screening in a hospital setting and mentorship. We ask you as a part of the registration, who are your most likely partners? And this will be the final two questions that we pose when we get to Q&A. And what I would like for you to think of this as is like, who else sees it? Because those are your partners. Who else can see it? One of you mentioned EMS, emergency medical services. And the reason why that one is so important is often the person who sees it as someone who goes into the home. I'm excited about this partnership. I don't feel like I've ever done good enough, well enough in intersecting aging and public health. Finally, because I want to get to Megan, I want to share a framework with you that I've used for more than 15 years. Um, this is your homework when you're done with the webinar. So you should write this down because this is my homework. I want you to think about, are any of the older adults you know abused? This is a question about prevalence and education. And just think about, are any of them abused? Do you know who they are? This is a harder question. And that's a question that really causes us to focus on both identification and screening. And the third question is the hardest, and it's about what each of us, I think, need to commit to personally. Do you know what they need from you? It's very easy in approaching this work to be both ageist and paternalistic. It's really important when talking about the needs of older adults that they be included. And one of the things that you can do as you expand the work in public health is to make sure that you tap into and listen to the voices of the people that we're trying to help. So if we all did those three things, I think we could change the world. I think those questions are that important. Megan, let's go through your toolkit.
Great. Thank you so much, Kathy, and thank you so much to NRHA, Becky, Laura, Alan, and Amy. I really appreciate being here today, and it's just a privilege to talk about the public health perspective on elder mistreatment. And I appreciate, Kathy, your knowledge, your context setting, great questions. A lot of what I will be sharing is kind of a systems approach, but I think that if we keep in mind the personal approach, it will help make this work much more effective and much more meaningful. So I'm here today to share a new resource that we have developed at TIFA as part of our age-friendly public health systems movement, and we call that APHIS for short. The goal of APHIS is to support the expansion of public health practice to better support older adults, and we've been doing it since 2018. We've seen tremendous growth, but there's still a lot of room to grow. Our Elder Mistreatment Prevention Toolkit is one of the resources that we have developed to do just that. Next slide, please. So just a little background on TIFA, Trust for America's Health, or TIFA, as we're commonly known. We are also a public nonprofit, independent, nonpartisan. We focus on public health policy, research, and advocacy. We're dedicated to optimal health for everyone with a focus on equity. TIFA is best known for our anchor reports that we publish annually, like Ready or Not, on the readiness of state departments of health for all types of public health emergencies. And we also periodically publish briefs through our APHIS movement, like the one you see pictured here, on the public health roles in supporting older adults in rural settings. And you can find all of these reports on TIFA's site, but the ones related to healthy aging or older adults are on the APHIS site, afphs.org. And we are also proudly supported by the John A. Hartford Foundation, which really is not just our funder, but really a partner in this work with us. So thank you to the foundation. Next slide, please. Our Elder Mistreatment Prevention Toolkit is our most recently published resource and was created in partnership with the National Alliance for Caregiving, the Education Development Center, and with the foundation. Next slide. With the toolkit, we hope to better equip public health practitioners and their partners, no matter what sector they represent, with the strategies and tools to prevent and address elder mistreatment, regardless of setting. And as with most of our work, this toolkit is organized according to our APHIS 6 C's framework. And I've noted the 6 C's or tenets here on this slide, and they are creating and leading change around older adults, connecting and convening partners, coordinating existing supports and services, collecting and translating public health data, communicating information, and complementing existing public health programs. So we find that these categories of activities or roles help public health professionals see themselves in the work and identify with these roles. So I'm going to be walking through our toolkit, which is aligned with these roles, and this will hopefully flesh out a little bit about what each of these C's or the tenets actually mean as well. So next slide, thank you. So to access the toolkit, you can navigate to afphs.org or just Google Age-Friendly Public Health Systems, or you can use the QR code on the screen, and the toolkit is featured right on the landing page right now. So just click on that scan that QR code, and it'll take you right to the toolkit. Next slide. So the first thing we did to develop this toolkit was to conduct an environmental scan, and that scan is actually linked on the page, so you can take a look at that. It has a number of resources. It has definitions. It's got just kind of goes through an analysis of what was out there when we started. And then we conducted interviews with experts in the field to identify what already existed and what was needed specifically for the public health sector. We spoke to public health practitioners, national organizations, and national leaders like Kathy, who was one of our interviewees. And then we analyzed that information from all the interviews and incorporated strategies and resources that they all shared. Next slide. So one of the questions that we asked our interviewees was, is elder mistreatment a public health issue? And we heard a resounding yes. There are significant health impacts associated with mistreatment or abuse, and preventing it is or should be an important area for engagement by public health practitioners. I also want to note that elder mistreatment is not an inevitable consequence of aging. It is not, like dementia is not an inevitable consequence of aging. We are all aging, but that doesn't mean that we are going to experience some of these things that are becoming more prevalent in our communities. So let's talk about those health impacts for just a moment. Elder mistreatment may impede a person's progress toward optimal health, which is what we want for all of our individuals, our family members, and people in our communities. Mistreatment itself can be a source of injury, disability, or dysfunction. It can exacerbate existing health conditions or challenges, including heart conditions and mental and behavioral issues, and it can prevent self-care. So a quote from one of the resources that I'm going to share is that the field overall has a very limited evidence base and lacks critical research to support an understanding of what strategies are effective to prevent, identify, and respond to elder mistreatment. So we're talking to researchers. I think Carrie Henning-Smith is a great example of folks who are leaning into this issue and wanting to understand what strategies are effective. I don't think we're there yet. So it's really important that we work together across sectors to implement and to monitor these strategies as we work to support older people. Next slide. So the public health sector has many roles to play here, as I'm going to kind of detail in just a bit as I walk through the 6 C's. But that includes communicating, includes educating on those risk factors, serving as a community convener, developing and implementing screening tools and referral systems, and then providing supports for victims and for their families and caregivers. And we know that caregivers can be perpetrators, and we want to make sure that they have the supports that they need by public health or the aging services sector or other sectors who may be able to support caregivers to prevent the potential abuse or mistreatment. So let's see. Next slide, please. So when we're talking about caregivers, it is a really important role, and not just when it comes to elder abuse or elder mistreatment, but just supporting caregivers overall can help older people in our communities. So just a few stats here that were provided by the National Alliance for Caregiving, but also from our friends at the Rush Medical Center, which leads the Caring for Caregivers model and administers that model. So 45% of caregivers report they experience high intensity situations. And we all know that high intensity situations result in stress, result in emotion, and we can act out, right? I know it's happened with me in my caregiving situation. 64% of caregivers already work outside the home. That exacerbates the stressors on us. 1 in 5 caregivers report poor health of their own. We don't generally tend to take care of ourselves as well as we should when we're caring for other people. 1 in 4 caregivers are taking on debt due to caregiving, another layer of stress. And we know that if we can address some of those strains or some of those stressors, we can help to mitigate the risk of mistreatment. If we can embed caregiver supports into public health, healthcare, and aging services programs, we can reduce that burden on caregivers and hopefully prevent problems before they occur. Next slide, please. So in the public health world, and Kathy mentioned risk factors and protective factors as well, but we do like to talk about these risk factors and protective factors because this is where, as public health practitioners, we put on our prevention hats and we think about those upstream strategies that can be implemented in our communities. So some of those risk factors, and Kathy mentioned these, include cognitive and physical decline, financial strain, caregiver strain, social isolation, the number one risk factor, financial gain. If an older person experiences financial gain, that puts them at risk. The evolving and ever growing complexity of scams, and even ageism. Ageism internalized, or ageism being experienced in the community, or out there in the world. And then protective factors, and these are really important to think about, include emotional intelligence and resilience. And this is one of the roles that public health can play, is building resilience. Good physical and mental health, financial literacy, and that education around financial literacy is really important. Building coping skills into people as we're caring for them. Having a strong social network. And of course, Kathy mentioned this as the number one protective factor in rural settings, is that social network. But it's true in all settings as well. And then making sure that our caregivers are trained, have respite opportunities and supports, and then having really effective and widespread legal and advocacy programs is also a great protective factor. Okay, next slide, please. So I have mentioned the APHIS 6Cs framework, and you're going to see the framework on this next set of slides, interspersed with some examples that I've pulled out from the toolkit. So these next set of slides contain screenshots of the actual toolkit. So when you go click on that QR code or go to the toolkit on the landing page on our website, you're going to see the lines to click on for each of the 6Cs. So I'm going to go through those and show you kind of what those look like. So for each of the 6Cs, we provide a list of strategies. Those are on the left. And then next to those, a list of resources and examples that can be accessed to both describe the strategy and also guide next steps. And we've tried to make sure that they're all up to date. They may not be, if you use the toolkit and you find that there are some tools that are like many of the CDC resources may not be there anymore. We've tried to make sure that we're up to date on that, but please let us know if you find links that aren't working. We want to make sure that everything is as it should be. So our first C is creating and leading policy and systems changes. So these are systems level strategies that can have a profound impact on the success of an agency's work in this area. This includes ensuring that public health has the authority and resources to address elder mistreatment and to promote or engage in interagency collaboration. That's not always a given. Sometimes there are regulatory restrictions on interagency collaboration. So as a systems changer, we want to make sure that we're addressing those to enable smooth collaboration across agencies. We want to make sure that we're not hindering potential partnerships or sharing of resources, and that we are not enhancing or enabling silos to continue to occur. We want to dismantle those silos in this area so that we can have effective partnerships. Next slide, please. So again, for each of the C's, we're going to provide an example and a resource. So here, our example is the prioritization of ageism awareness. That is an area that the Maine Council on Aging is working very hard to address. We know that certain stigmas attached to age can be a risk factor for abuse. And then the resource that I've highlighted here is from the National Indian Council on Aging. So elder mistreatment in tribal communities may show up differently, but the questions that we can pose when developing or using a screening tool are not that different. So I wanted to show this resource as an example of how practical some of these tools are and note that they are appropriate in pretty much any setting, whether it's a tribal community, a rural community, or in my neighborhood senior center. So some of these questions are things like, is the elder in imminent danger? Is the older person able to talk openly about their care? Is the older person in need of emergency services? Hopefully, if you're in a senior center and these questions are in your head, that's not happening. But what is the nature and extent of that abuse or mistreatment? Is it likely to occur again? And what is the level of risk? So just a few questions that are at part of this toolkit or this tool from the National Indian Council on Aging. Please take a look at it. There are a lot of really good tools in there. Next slide, please. And I will go to the second C, which is one of my favorites, and I think one of the most important from a public health perspective, and that is connecting and convening multi-sector partners. For elder mistreatment, prevention, and addressing elder mistreatment, this is really a crucial area. The strategies we've included here are activities like engaging a multidisciplinary team to prevent elder mistreatment and to support victims and families. And then we suggest potential partners for a multidisciplinary team, such as adult protective services, of course, but also aging services personnel, physicians, mental health practitioners, and victim witness advocates. And you might even already have a group or a coalition that you're working with that may be willing to expand its focus to include elder mistreatment prevention. And then given the work that NRHA is doing with community health workers, they are a great potential resource to make connections between older adults and their families with those formal support systems. So Kathy, I'm going to pause there. I know you wanted to talk about multidisciplinary teams and just offer a little bit of clarification.
Yeah, I just wanted to chime in. Multidisciplinary teams, I actually can't say it. MDTs have two different functions. They're slightly different. I want to make sure that people know the difference. The most formal structure of a multidisciplinary team is to do complex case review of adult protective services cases. And for that to happen, there has to be agreement or statutory coverage for confidentiality of the APS client. So for a formal MDT, I think of it mentally as one with capital letters. Who you'll find will be APS, law enforcement, a social services agency. They'll bring in a geriatric psychiatrist if they need one. And it really are professionals who can help with a case that's presenting very complex issues. I don't know if public health would be in that team. I mean, maybe. I mean, it depends on whether there was a resource that the case or the client needed. The more general, I think of them as the non-capitalized multidisciplinary team, is a strong community coalition of the type that you're listing here, where you bring all the partners in of people who touch this issue, touch the people impacted by the issue and their caregivers, and look at systemic issues more than this is this person's case and this is the problem with this person. But there's a lot to be said for a community coalition in knowing which in our community is doing capacity assessments. What are we going to do about housing? Who does mental health support? Those kinds of systemic issues is very important, and it can be there can be a huge opportunity here for public health to partner in that. But they're slightly different in purpose, and one is much more legalistic in structure because of confidentiality. So I just wanted to chime in on that.
Yeah, no, I appreciate that clarification. It just gets me thinking too about some of those non-usual partners that we can think about, like librarians, like thinking about not just your physician, but maybe your pharmacist, who knows people and sees them frequently. Anybody who touches an older person's life on a very routine basis can potentially be a partner in an MDT. And so those are folks to think about. So thank you, Kathy. Okay, next slide. And we'll look at our example. It was actually also another one of our interviewees for the toolkit, and that is the Summit County, Ohio Health Department. And they actually have served as the convener for their elder mistreatment work for many years. And they have led a multidisciplinary team with multiple partners across their jurisdiction to identify victims of abuse, to provide education, to provide referral services. They have been doing this for years and have a great system. And the resource that I'm highlighting that is linked in the toolkit is the MDT guide and toolkit on how to develop an elder abuse case review MDT. So again, a very practical tool for that formal process that Kathy mentioned, but it can provide some additional information and guidance on developing even just a coalition. And we have other resources in the toolkit linked, which can help you think about different partners and different roles for various partners as well. So great resources. One of my favorite things, just a quick aside, one of my favorite things about this tool and the other tools that we've developed are the list of resources that we provide and trying to bring everything into one place. We know, however, that our list of resources is not exhaustive. So again, if you come across additional resources that you think might be beneficial to others accessing the toolkit, please send them to us and we'd be happy to update the toolkit to include them. So our next C3 is coordinating existing supports and services. So this is thinking about, this is not the same as connecting and convening, because this is thinking about what programs already exist that are working to help families and to help supporters navigate what can be a complex system of supports for older adults. So this can include, our strategies here can include things like integrating screenings into already existing public health clinical settings. It can include collaborating with those who are engaged in outpatient work and helping older adults. It could include strengthening partnerships with other community organizations that touch older people's lives. And so it's really thinking about what already exists and how can those existing programs be better coordinated. We've seen a number of health departments at the state and local levels who have created hubs of information for older people, for families, for caregivers to go to, where they can find everything that they need, kind of like a no wrong door approach. And I'd love to see that happen too for elder mistreatment services. Next slide, please. So on this slide, I want to commend to you Maine's Elder Justice Roadmap, which is a very thorough guidance document for identifying abuse and providing a multidisciplinary response to it. And this is where I have the animation, if you could just advance the slide one more. So the guide includes some great references, guidance, evidence-based steps for training and education. I think this is an area that we don't talk about enough, is the need for training and education, and not just for public health, but for all partners who may want to engage in this issue in partnership with public health and others. So they suggest in Maine's roadmap, they suggest adding an elder abuse investigator training to their criminal justice academy, expanding training for APS staff or any public agency staff, and mandating training for mandatory reporters on their responsibilities. So in every jurisdiction, there are folks who are required to report instances of abuse or mistreatment, and there should be mandatory training so they understand what responsibilities are, and particularly if the legal landscape may be changing. Every time that changes, there should be just a regular update on responsibilities, and adding that to the education and training for public agency staff. Next slide, please. So the next C is collecting and translating data. Public health people love data. Unfortunately, there is a lack of data on elder mistreatment, but this is where engaging with your public health partners could be quite valuable. Public health folks can help to educate partners on data and the importance of data that can help direct resources where they're needed and interventions and programs where they're needed. That's what data tells us and what it can help us do. We also highly recommend using the community health improvement process to collect information on older adults. So the public health departments at the state and local levels are required to do a community health assessment periodically every 3 to 5 years. And they engage partners in this process to identify what are the challenges, What should the priorities be? And that's where the funding streams and the interventions are directed. This might include elder mistreatment prevention and support for victims and families. So we include links here on this part of the toolkit to some of the public health resources on the community health assessment process, many of which are provided by our partners at NRHA, the National Association of County and City Health Officials. And if you go to the next slide, I love this example, and I think Dr. Keena White is on the call. I saw Keena's name. So the Mississippi State Department of Health they developed data profiles on older adults to capture the health status of older adults across the state. And we learned that that one law enforcement official used information from the data profiles on falls and fractures to identify areas where an elder abuse prevention program could be implemented. So that's just a great example of what thinking about data on older adults and injuries, hospitalizations, falls. What does that tell us? Data always tells a story. So what does that data tell us in one community that can help us make sure that we're implementing the kinds of programs and making the systems changes that are needed to help older people in a specific area? And then, of course, the Caregiving in the USA report from AARP and the National Alliance for Caregiving talks about transforming family caregiving through data. Again, data tells a story, and we love to highlight this. But it's a great compendium of resources on caregiving, and just gives you an example of how data can be used to kind of tell those stories and see our family caregivers a different way. Okay, next slide, please. Our fifth C is communicating, and this is such a crucial and historic role for public health agencies. So the information on this slide is related primarily to financial abuse, and I want to note that there are a lot of federal resources that can be shared with people in your states and communities to prevent financial abuse, to better understand it, and to provide education and training around it. It is a slippery slope right now. It is a complex process with the advent of more AI. Things are just kind of going crazy right now with financial abuse. So it is a moving target, but one that we have to stay on top of. And the next slide, please. So our example for communicating is from the Maryland Department of Health, which offers a brochure that provides an overview of elder abuse along with a web page that links to several related resources. So this is just a great communication tool that is on their website. And then the resource on the right is one of the Consumer Financial Protection Bureau's guides on how to protect family and friends from financial abuse. So it's a very accessible tool. It uses a real life scenario to demonstrate how the tool can be used. So very easy, very clear tool to be able to put into effect. Next slide, please. So getting toward the end, so we want to make sure we have time for some discussion. So our last C is complementing existing public health programs. So some existing public health programs, believe it or not, don't include older adult focus. So we try to encourage public health practitioners to expand existing programs to serve the entire population, including older adults. So this may include expanding mental health screenings or working with existing coalitions to provide education on elder mistreatment risk and protective factors. It may include screenings in home wellness visits or when you're doing a home vaccination administration. There are many different existing health promoting programs that can be just be complemented or expanded with an additional focus on older people and potentially with the screening tools for elder mistreatment. And the next slide, my example here again is from Maine, where several agencies collaborated to create the Elder Justice Coordinating Partnership to guide the state's efforts in responding to and preventing elder abuse. So a key component of that initiative is their Elder Service Connections, which enables their adult protective services to refer a victim to an advocate through their Elder Abuse Institute of Maine. And then so a really interesting and very formalized collaboration. The resource is from Maine's roadmap, showing some of the ways that information can be shared through podcasts, webinars, briefs, and toolkits. So just really kind of building out programs that may already exist. So next slide, and this is my last content slide. So I just want to leave you with this message from the Maine Elder Justice Roadmap, and that is that we're recognizing just how crucial it is that a cross-disciplinary approach will address the abuse and generational trauma that some older people experience. And I just think that's an important aspect of this work to keep in mind, especially that generational trauma. And there are ways that public health is working to address trauma, but I think that we need to think about that generational trauma as well. So I hope the message resonates with all of you. And I'm just looking forward to the discussion today. Thank you so much for allowing me to share our toolkit. And I hope that you all find it useful.
Thank you. Thank you. Such a rich toolkit. Megan, you bumped into one of my soapboxes, and I have more than one, so this isn't a great big surprise. But when you mentioned data and data collection, this is my soapbox. It's really important for older people that we disaggregate the data. And you have wonderful examples from Maine. The Maine Council on Aging has done that. We tend to see in aging like 4 decades of people all lumped together, 65 to 105. And when you do that, you mask sometimes the greatest need, like poverty. I did a speech on this 2 weeks ago. The poverty numbers change if you look at older adults when they reach the age of 80 or 85. The data changes if you look at older people and look at both gender and race and ethnicity. And the lower ages in that 40-year age range creates a smoothing effect that kind of masks where the big trouble might be in terms of where the greatest risks are. So I just encourage all of you who are working on data to look at it. Sometimes I think people don't gather Medicare data for whatever reason, but it's just really important that we not talk only about everybody 65 plus, and especially from a public health perspective. You will miss the greatest risk if you do that. So let's do some Q&A, and you can raise your hands. These were 2 discussions. We'll talk to anything you want to talk about. We'd ask about this to get you thinking when you registered, who are your most likely collaborators, because we really want you to give some thought to that. And Megan had some great examples of the ways you can integrate elder abuse prevention and response into your work. I'm watching the chat, and I want to see, if you raise your hand, I've got the participants open. I think I can see, or you can shout. We'll do that too. So does anybody have questions, answers? Good examples that you want to share? This is also a good opportunity to show off if there's something that you're doing that you want to make sure we all know about.
Could we maybe take the slides down so we could see everybody? Might that be a way to do that? And maybe put the questions in the chat so we still have the questions.
Yeah, yeah.
Yeah. And Kathy, I would like to climb on your soapbox with you because
okay, yes.
Yeah, I think those of us who are 65 or older 65, we are not, I like to say we're not homogenous, right? We're not all the same. And I so appreciate your pointing that out.
Anna.
Hey everyone, this is Anna Thomas with the National Center for State and Tribal Elder Justice Coalitions. Megan, this was fabulous. Thank you so much for this. I have a question for you about your toolkit. If there is a companion resource, can we just send that to you for you to link into your toolkit? Is that the best way to just email you the link?
That would be terrific. Yes,
Fantastic.
Absolutely.
Great. Thank
Love
you.
having it. Thank you.
Do you want to tell us more about you want to tell us what you're thinking in terms of the link?
Yes, I totally can.
So
here at the National Center, we developed a resource for elder justice coalitions that are states or tribes that even want to start one. We take them all the way from, hey, we may need an elder justice coalition here, all the way to, we've been going strong for 10 years now. So we have equity pauses built into the resource guide, and it is very inclusive of all different types of older adults and adults with disabilities. and far-reaching, and it goes into the multi-sector. How do you bring people to the table? Who should be at the table? It's very similar to building that table, like you mentioned, and making sure that the right people are there, but also people that you don't normally think about that should be at the table. Public health being a great one. So I would love to. I'll link it in chat if anybody's curious to look at it, but I'll also send it to you, Megan. Thank you.
You're right, and getting good comments in chat from Tasha Jones, who said they've used it. So
awesome.
Yes,
Great.
Even better to build one that people use.
Yeah,
So,
that's fantastic.
that's good. Other comments or questions or dialogue?
I have a comment. I have a comment. So this is really great. I remember working in a care facility and they had this monthly training for the staff. They would always say, okay, read about this. Like we watch a video of somebody abusing an elder and the consequences that they face. So I thought that was really helpful because when people know about the consequences they face when they abuse an elder, they become more alert. And not just knowing about the consequences, but the awareness that they created for the staff was really very impressive for me. So I thought to share that as well, that when you are thinking about collaborating with existing public health professionals or services, we should also think about elder homes facilities that are already existing because that is where we find most of our elders. And just as you said, they always put like different age groups together, and we don't know how to even treat people who are like 65 from people who are like older or people who have cognitive impairment and everything. So I just thought to mention that we should always think about the elder care facilities as well. Yeah.
Good. Thank you. Thank you. Thank you. Yeah, 65 and 85 are not the same age. You want to talk about falls and the difference? I mean, there's some serious public health and health consequences of frailty or just older age. But Becky, thank you. Yes. And we should not forget about people in all kinds of care settings. So. Anybody else want to make a comment? Yeah.
I'd love to, raise the question that you and I had spoken about how this can look different in the rural community. I mean, it ran throughout Megan's presentation, but just, those examples of if we wanted to use like a specific example of what this could look like, in a rural facility, or a rural community. If anybody else on the call has an example about how they've seen this in the rural communities that they've been serving, what else would be helpful?
I often think about, first of all, we should have someone answer, not me. I also think about regional approaches when you think of rural communities. And I might, as an example, pick on my good colleagues at Weill Cornell Medical Center. Nancy knows our friends at Cornell. I visited them several years ago and we talked about their multidisciplinary team. And they were talking about having a geriatric psychiatrist. And I said, I really think you should describe the functions that you need, not the credential, because we might have a master's level social worker doing that. And then we really need to pay attention to what are the functions in all communities because we don't all have the same access to resources, but the needs can be very similar. So thinking about who's in the community, who's in the adjacent counties. I mean, how do you really approach? And I would hope, and again, I'm just like a friend to public health. I don't come from public health. I would hope that public health would be a good avenue for building those kinds of regional networks and sharing of information across regions. Because public health by itself, at least in my state, like 2 people in a county. I mean, so it's very small where you have to, reflexively build those coalitions across different public health departments in rural areas.
Yeah, and public health looks different everywhere. As you said, Kathy, in one local health department in a rural area, you might have one public health worker, and they're responsible for for so many things. And you may have a state like Mississippi where there aren't local health departments, right? They're regional work, and there's certainly public health people across the state. But if you don't have the actual department, you have to be creative in thinking about how are you going to reach public health, how are you going to engage with public health, and thinking about how can you connect it with other public health work.
Megan, thank you for that. And to highlight Mississippi as well, Dr. White's work and their leadership there. One example was working with the mayors and bringing them together with public health. And one of the mayors highlighted at their Healthy Aging Conference was bringing together older adults at like a bingo setting, like to come in and bring back cohesion and then utilizing the guidance of those older adults, the leaders in their community to find out where some of, the services were most needed and connecting those leaders with the priorities that public health was highlighting for the community. Because they said if you wanted it done, you went to this section of the population, who were some of the older adult ladies in there. So you're right, like public health is there, but how do we bring those teams together? And it looks different in every rural community. So yeah, that's great.
Kina, will you come on camera? Are you camera ready?
Yes, I'm in my truck.
I was thinking the
Yes.
same thing. So thank you for chiming in about faith communities. I mean, I think they are important partners in rural communities. So we all think you're great. Is there anything else you want to add from your talk?
No, well, I was gonna echo the mayor context that Laura shared. So we have found, and especially in our smaller communities, sometimes the mayor is a pastor.
Yeah.
We have that quite frequently in Mississippi, and so our mayors, as well as our faith leaders or champions, they have also been phenomenal advocates for helping to expand our age-friendly public health work, but also to be a champion to addressing some of the barriers. I will say, since Mississippi does have a centralized governance structure, we do not have autonomous local departments, and so sometimes it takes local faith leaders to really nudge the politicians and help them to really see the value of addressing age-related priorities, because we have seen significant challenges with that in our rural communities. And now also being able to see a regional collaboration across parallel counties. So Arkansas and Mississippi are now collaborating more. Louisiana, Mississippi are collaborating more. So those contiguous counties where we have populations that may cross over state lines to seek better care, we're starting to see increased communication in that space as well.
Awesome. Thank you. Thank you for letting me call on you.
You're welcome. And my allergies are terrible. That's why I keep wiping my face.
All right. It's all right. Megan, we had a comment in the chat from Chris Wilkes. Chris, are you camera ready? You could call from your truck. I just wondered if we could talk about your question out loud, or at least have Megan take a look at fraud, waste, and abuse. And
here we go. Hi.
See, you are camera ready. Yes.
So you just wanted me to talk
Yeah,
through the question?
yeah.
I just wanted in putting together the toolkit or doing the interviews or people talking about the sort of competing priorities that are handed down from the federal government. And as we all know, there's a lot of focus right now on fraud, waste, and abuse on the fraud side. And so just wanted to get a sense of how using the convening role of public health, we can, you've seen examples of shifting the conversation back to protecting older individuals on the abuse side. So that was sort of the question, if that makes sense.
Yeah, I think it makes sense. I think it could be challenging because a lot of times if there is a focus, especially if there's funding or if there's authority in one area, if it's restrictive, you may not be able to have those personnel work on other issues or use that funding right for other issues. But I think it certainly should be, and I think that if there are opportunities to broaden the definitions of fraud, waste, and abuse, that's maybe something to think about. I haven't heard of that happening, Kathy. Okay. I don't know if you have, but I have not heard of that kind of a shift.
I was just going to suggest the State Medicaid Fraud Control Unit, which you say out loud as MAFUCO. That's how they say their acronym. As a good partner.
Okay.
In Kansas, the Attorney General has not quite the same type of coalition that Anna is talking about, but we have a statewide committee, and the director of the Medicaid Fraud Control Unit is on that statewide committee. So at least at the state level, as you're looking at coalitions, I see some opportunities from that office. Not so much in a more regional or local level.
Mm,
But they would be a good partner to talk to.
Mhm.
thank you.
Christy has a question in the chat.
Hi, Christy. Yeah, so there are examples of local health departments engaging in this work. I mentioned one of them, Summit County, Ohio, which has been actually leading this work. And because of their leadership in this area, they have been able to secure public health funding through their the funding that flows from the state health department to the local health department, but also local health department funding that does support those activities. So I'd be happy to connect you with them if that's something that you'd be interested in doing. I'm sure there are other examples that I don't have on the top of my head, but definitely they're there.
And on the prevention front, this is a good audience to talk about prevention with. It's like, what is it? Because I think in the field of aging, we've had some struggles, and really the best way to boil down prevention is it's risk mitigation. How do you mitigate the risks that are facing people? And in this context, your talk about family caregivers is really important.
Mhm.
That mitigating the risk for the older adult, mitigating risk, providing support for caregivers. It's all about mitigating the risk. There are crimes that happen, and we should prosecute the crimes and refer to law enforcement. There are often people who need help, and we should, in many times, look more for help and less for blame and try to help situations and improve the risks that people are facing as they get older and the caregivers who are trying to care for them. So, but
Yeah.
I'm not Pollyanna, not all families are charming. So there are true horrendous abuse situations, then we need to get to law enforcement. So
Yeah. And I think we have to be always really sensitive and very humble because a lot of times older adults don't want to admit it. They don't want to admit that something has happened to them or is happening to them because it feels like a failure on their part. And so I think that we have to just always be very, very sensitive when coming into this work.
and I can tell you why. Because what we all want most is to remain independent, all of us. And that's what older adults fear is I'm not going to admit that someone did this or that to me because I don't want you to make me move out of my house. I don't want you to report me to APS and have them put me under guardianship. I don't want to lose my independence by admitting this problem. So there's a reason behind it, as troubling as that is to the rest of us. So how do we, in a respectful way, provide the support and the independence? And sometimes the person who's the perpetrator or the person causing harm is a loved one in their life they don't want to lose. So you just have to start where people are in a
Yeah.
real open and non-judgmental way and try to lead by asking them what they need and always support. My third question, what do they need from us? Other things, I know we're about at time. Do I need to give this back to anybody? We got more stuff in the chat. I never was a bartender, so last call. I didn't do that. Um, Anybody have anything else? All right, Megan, thank you for all your work. Thank you for your
Yeah.
partnership. I'll tell them about our first conversation. I got so excited. We'd never
Yeah.
met, and we all knew the same acronyms, so we felt like we were starting our conversation in the middle. So it was great.
That
So
was.
it was very good. All right, Becky and Laura, Megan and I are ready to turn this back to you.
Thank you so much. So we are going to the next steps, and I think Laura has to do that. So I will just give it to Laura. We are ready.
No, thank you so much, Becky. I will echo. Thank you, Becky, for creating this webinar and coordinating it for us. Thank you to Kathy and Megan for such great content. Thank you to you all, the attendees, for great context and the good work that you're doing and for your interest and heart for this conversation. Becky put a couple of activities that we have coming up related to the initiative. We also have an opportunity on that resources hub that I put in there for you to share your resources with us that you would like included on the resources hub. So with that, we'll just say thank you so much for attending. Thank you for the good work that you're doing, and be well.
Thank you all.
Thank you.